Good morning, everybody, and welcome to our webinar. And I want to thank everybody for joining us today. I'm very glad that you're able to all connect in with us. And my apologies for a slight delay there. But hopefully we've got everybody live and going now. Just to let everybody know that we do have quite a number of paramedics here today. In addition to the paramedics, there may also be some paramedic students from the 3 colleges that we have. And as well, we also welcome some special guests who are here with us today, and that would be the members of the London Minor Football Association, a number of coaches and trainers that have also been invited and may be participating here in our webinar. If it's your first time on the webinar, just to let you know that you have many options is what you can do today. You can watch and listen and just enjoy the presentation, pick up all the information. If you want to get more involved in a few minutes on a couple of the slides, we're going to have some polls pop up where you'll be able to vote on some questions that we have for you coming along in there. Even more so, if you have the desire, there's a chat box. You'll see a chat box on your control panel for the webinar, and you can type questions in there. I'm what they call the old man behind the curtain, so I'll be chatting away with you in the background by typing. I can pass your questions along to the presenters. And if you really want to get involved, we do have the opportunity for you that you'll see on your control panel for the webinar. You'll see a little hand. And if you click on that, I'll see that your hand is raised. And if we have time, we'll be able to open your microphone, and you'll be able to ask questions. As long as you've got a microphone on your computer, you'll be able to ask our presenters your question directly. So our 3 panelists today, we have Dr. Samir Mal, who is a 4th-year emergency medicine resident here at UWO. He's also doing a 1-year subspecialty in EMS. So he's our EMS fellow for the year, whereas Samir likes to call himself Matt Davis 2.0 because he's following in the footsteps of Matt. So many of you have already gotten to know Samir very well by watching the pre-course webinars for the research program. Also joining in today for this webinar, we have Dr. Justin Yan, who is a 3rd-year emergency medicine resident here at UWO. He did his 1 month of EMS rotation with us. We kind of extended that a little bit. We kept him around a little longer to make sure he got involved in this presentation. And finally, we have Terry Lynn Potajnik, who is a registered nurse and injury prevention counselor, a specialist in this type of information from the trauma program here at London Health Sciences Center. So I hope everybody enjoys our webinar. It'll last for about 1 hour today. There will be some opportunities for questions along the way, we hope. And for those who want to watch it afterwards, this will get recorded and posted to our Base Hospital website so that you can always review it at a later date. So that said, I'm going to turn the presentation over now to Samir.
Hey, good morning. Great, good morning, everyone. Thank you very much for curling up with us on a Friday morning to talk about concussions. We really appreciate everyone's attendance this morning. Over the past few years, there's been a lot of press devoted to the topic of concussions, especially in professional sport. And in the general public, it's created a lot of interest, but also created some misperceptions about concussions as well. It's our hope that we can shed some myths and give you some useful information to take home so that in the future you'll be able to appreciate and recognize the significance of head injuries in the future, whether it be with your patients, players, friends, or family members. On this slide right here, we have the learning objectives for the session. At the completion of the session, we're hoping everyone will be able to discuss the prevalence and common causes of concussions. Secondly, describe the term concussion using basic anatomy and physiology. Next, we'll be summarizing some of the key assessment tools and treatments that can be performed by trainers, coaches, parents, and responding paramedics. Next, we'll move on to explaining both the short-term and long-term consequences of concussions. And lastly, we'll finish up with talking about the recommendations for appropriate return to work or activities following a concussion injury. So to start off the presentation, we thought we'd be a little interactive, and we'll start off by presenting 3 cases, all real, that have presented to LHSC within the last few years of people who have suffered a head injury. And kind of using the technology that Dave's been able to put together, we're hoping you can all give us your opinion on whether or not you believe each of these patients has suffered a concussion in your mind. So, starting off with case number 1, we have Justin, who is a 12-year-old male, trying to master his skateboarding tricks at home, falls off his board while he's attempting to jump a curb and flies forward into the brick wall of the school, head first, not wearing a helmet, obviously, like most 12-year-olds. Had an immediate loss of consciousness, and in quotes, he felt like a rag doll. He suffered a generalized tonic-clonic seizure lasting about 30 seconds shortly after his head injury. And I'll pass it over to Dave.
So the poll's on the screen. So if you take just a minute and if you click away and make your selection, decide whether or not you think that poor Justin could have a concussion here. Just a couple more seconds. Okay, our first poll is closed there, Samir.
Okay. So moving on to case number 2, we have Adam, who is a 23-year-old defenseman for the London Knights. He was slammed hard into the boards behind the net during a game, maybe had a stick to his shoulder or neck, unsure. He stumbled, but he recovered his balance and continued to skate in the end zone. He was shaking his head, coasting, and he bent forward with his stick across his knees to balance himself. Adam does make it to the bench and sits down.
All right. So once again, very quick poll for everybody to get their feel for the situation.
All right, now our last case is Marla, 47-year-old mother of 2, who's at the Western Fair with her teenage daughters on one of the new coasters they have. She hit her head on the side of one of the cars as it whipped around a hairpin turn at the base of a large drop. She finishes the ride and stumbles off and is complaining of some dizziness and nausea afterwards, but does not have any vomiting.
And the one last poll. I think everybody's used to the possible selections here.
Okay, so we have our results here. They're just being forwarded over to me. For case number 1, for our little skateboarder, we had 94 people, 94 responses for yes, 3 for no, and 3 unsure. So overwhelmingly, number 1, according to the audience, has had to suffer a concussion. Case number 2, about our defenseman, we had 70 responses for yes, 7 responses for no, and 19 of you were on the fence. So once again, the majority of the audience believes our hockey player has had a concussion. And lastly, our mother trying to have fun at the Western Fair. She had 81 responses for yes, having suffered a concussion, 11 for no, and 7 unsure. So the overwhelming majority in each case was positive. Now I will pass the presentation on to Terry Lynn to give you some of the basics and background about concussions.
So trying to understand what a concussion is. As professionals, we have a better understanding of what concussions are, and we still can't come to agreement whether one is or one isn't. And that's because there's long-standing misunderstandings that are in the general society, and we've grown up with them. A lot of people, we've also participated in sports and feel like, oh, he just got his bell rung, or he can just shake it off and get back in there. He hit his head. It's part of the game. I've heard all kinds of them. He's just got a bruise to his brain, or he's just punched drunk. He'll come around. It's okay. He can go back out there. I think it's taken many years, and really it wasn't until Sidney Crosby suffered his major concussion that's really got the general public talking about it, and the awareness is increasing out there, but there are still many concussions that are unrecognized, and therefore they're not managed properly. In children, many parents don't know that their children have suffered a concussion. Brain injuries are hard to detect. Kids are not able to articulate their symptoms, or they're confused. And a lot of parents go, it's just adolescent drama. He doesn't want to go to school. That's why he's got his headache. And it goes on and on. So increasing awareness is important. As well, when you go to a field, or if you're a coach, when you're dealing with parents and kids, they're going to downplay it as well. So it's partly our our role, I guess, as educators, so that we can educate them along the way so that they know exactly what's going on so they can make appropriate decisions. So what is a concussion? There was a consortium that's been held the third time now. Last one was held in Zurich, where all the professionals that know anything about concussion, from sport concussion, doctors, there were psychologists, physiotherapists, the works, they got together. And they've come up with a very comprehensive definition of what concussion is, although it still remains quite vague. It's defined as a complex pathophysiological process affecting the brain induced by a traumatic biomechanical forces. So there are several common features that incorporate clinical, pathologic, and biomechanical injury constructs that may be utilized in defining the nature of a concussive head injury. And these include concussion can be caused either by a direct blow to the head, but also the face, the neck, or anywhere on the body. Anywhere where there's this impulsive force transmitted to the head can lead to a concussion. It typically results in a rapid onset of very short-lived impairment of neurological function that resolves completely spontaneously. Concussion may result in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than a structural one. So there's nothing that you could visualize on a CT because the head has just been shaken around. Concussion results in a graded set of clinical symptoms that may or may not involve loss or consciousness, and that's one of the misconceptions out there, that you have to lose consciousness to have a concussion, and that is not true. And resolution of all of these symptoms typically follows a sequential course. But it's important to note that not everyone is going to recover at the same rate, and that some people, their concussions and the side effects and the experiences of their symptoms can be quite prolonged.
We're just going to go over some very, very quick and short anatomy about the brain regarding concussions. So there's there's three major divisions of the brain: the cerebrum, also known as the cortex, the cerebellum, and the brainstem. And the cerebrum or cortex is divided into four general lobes: the frontal lobe, which is responsible for motor functioning and executive function; the parietal lobe, which is primarily responsible for sensation; the temporal lobe, just over the temples, which is responsible for smell and sound; and the occipital lobe, which is responsible for vision. Their cerebellum is responsible for coordination of movement, and the brainstem at the bottom of the brain is really responsible for cardiac and respiratory function. Around the brain and the spinal cord, it's surrounded by cerebrospinal fluid, or CSF for short. And really the purpose of the CSF is to provide a fluid pathway for delivery of substances to and from the brain, nutrients, and so on. It also provides a buffer during trauma for the brain and the spinal cord, and that's relevant for concussions, as when there's a direct injury to the head, the CSF works as a buffer to protect the brain a little bit.
London Health Sciences Centre, we have pulled some data looking at concussion and the numbers of concussions in patients that we have seen that have come into the hospital with concussion. And essentially, adults that are considered anybody older than 18, they've had an average of 472 concussions have been seen in our emergency department over the last 5-year period. In pediatrics, the average is 342 cases per year that come in. And you'll notice that the graph is increasing. There's actually been an increase in the adult population of 53% over that 5-year period. And in pediatrics, it's gone up by 18%. Why is it increasing? We're unsure. We can only speculate. Possibly it's because of increased awareness around what concussion is, and more people actually coming in to seek treatment for minor brain injuries. So when we look at how they actually get their concussions, in adults, the #1 reason is falls. followed closely by motor vehicle collisions, and then struck by a person or a thing. And that's where the majority of sport concussion are going to fall into this category. And we'll look at the breakdown of that category in a minute. Children's picture, it looks a little bit different. Struck by a person or a thing is actually the #1 cause. So sport-related concussion is much larger in pediatric population at LHSC than in the adult population. That's followed by falls and then motor vehicle collisions and cycling injuries. So in adults, when we look at this category, struck by person or thing, we're actually looking at a small number of patients, totaling 393 patients. The total number when we add up all the sports combined, so we look at hockey, soccer, football, skiing, all of those things, it totals 38% of concussion. The other are struck in non-sports related activities, which is struck by or falling or walking into a post, a sign, a tree, those kinds of things. So if we add up all those sports, that totals 38%. In the pediatric population, that category was much larger, so we have a total of 740 patients in this grouping, and 77% of those are related to sports, directly related to sports. And you'll notice in the adult population, hockey was the #1 sport for sport concussion, and in pediatrics as it is as well. So in the adult population, 12% of the reduced 393 cases or patients, it totaled 48 cases. In adult or in children, that's much greater. Children in this category, we actually saw 257 children coming to the emergency for a concussive injury.
So as Terry Lynn was alluding to earlier in terms of what happens when a concussion occurs, it's really due to an acceleration and deceleration of the head and the brain. So in our cases when we were hearing about a skateboarding injury or whether it was the London Knights hockey player or even on a roller coaster, really when a head is accelerating and then has a sudden deceleration, a concussion can occur. In the brain itself, what actually is occurring is that there's the injury can actually distort and stretch the blood vessels and brain cells and affect their functioning significantly. And what Terry Lynn was saying was that we don't always see evidence of concussion on something like a CAT scan or even on an MRI, but it is a functional problem that occurs with a concussion. The idea with the coup versus contra coup, and that has to do with something related to the anatomy anyway, is that the coup is actually the direct injury where the person hit their head. And because the brain is suspended in the CSF, the contra coup is really the opposite side of the brain that can get injured when the brain is shifting within the CSF and hits the opposite side of the skull. So as I was mentioning, with the concussion, you can have a direct injury where the head strikes an object or its motion is stopped by an object, such as the ground or a post or whatever, and then the indirect injury as well, when the brain is moved quite quickly and rigorously within the skull. And there can be shear and strain injuries when one part of the brain slides past another.
Okay, sorry guys, I'm just going to jump in here for a minute. There's a couple questions that are coming in off the chat. I thought maybe I'll present this to the presenters right away and see what they think. First question came in, is there any kind of synthetic substance that would be similar to CSF or even something with the ability to increase CFS to provide like increased protection?
Okay, so that's a good question. The answer to that right now is no. We don't. I am not aware of any real or experimental therapies of injecting CSF into the skull. Now, then, mind you, the skull is an enclosed space which is unable to expand. So the brain and the body is very good at regulating the pressure inside of the skull, so that your brain is still getting blood flow and able to get nutrients for all of its cells. So artificially increasing CSF would potentially be a lot of problems. So no, I'm not aware of that right now.
Okay, and thanks for letting me put you on the spot there, Samir. Another question, are there any other tests other than a CT or an MI that would help detect a concussion?
Yeah, actually, that's an interesting question. structurally, the idea with concussion is that it's not a structural problem, such as seeing an obvious bleed or something like that, which you would see on a CT or an MRI. Now, there are PET scans, which positron emission tomography, I think is what it stands for. PET scans, which are very advanced scans that really check the functioning of the brain in terms of blood flow and the metabolism of the brain cells. Now, that's not a test that we can order routinely from the emergency department in LHSC. I think there is only one PET scan in London at St. Joe's. That's really for really advanced testing for patients with, advanced cancer within the brain and so on. There are PET scans that do show that there are functional changes in patients who suffer from concussions. But again, that's not something that would really change the management of a patient who came in with a concussion. So in short, the answer is that yes, there are tests that could show differences in patients with concussions versus patients who don't have concussions, but that test really isn't available to us here in London.
And if I could just jump in as well, like Justin said, concussions are not an anatomical problem per se. The brain suffers a transient period of injury, and that we're not able to see those on any imaging. But that being said, there are history taking points and some standardized assessment tools which in concussion really take the place of having CT or MRI of making the diagnosis of following patients. We'll be going through one of the more popular, well-validated assessment tools in a few slides.
Great. Now, there is one question, but I think we'll wait a bit because I think Terry Lynn will cover this a little bit later about how long the symptoms can last, time frames, and I know Terry Lynn's got a good section on that. So the last question, just before we move on, does hypovolemia lead to any decrease in CSF, thereby increasing the propensity of injury to the brain?
So this is sort of where I'm coming with the slide that you're actually seeing right now. The point that I wanted to make with this slide, when the damage is done, the damage is done. So really, hypovolemia, it's not that it necessarily decreases the amount of CSF in the head, because the CSF it's around the brain, and it's not so much that the decreased volume of the bloodstream is what causes a decrease in CSF. But with secondary prevention, that's what I'm pointing out here, is that after someone has sustained a head injury, whether that's concussion or an even more serious head injury, really what we can do is we can secondarily prevent additional injury by preventing hypovolemia, by preventing hypoxia, hypoglycemia, for instance. Those are all things that once the brain is injured, we need to prevent from happening so that there's not more serious injury to the brain. And the point I wanted to make here as well with primary prevention is that, as I was saying, the damage is done already, but from a primary prevention perspective and a public health perspective, what we can do to prevent concussions and head injuries is encouraging people to wear helmets, protective gear, and so on. So really, the damage is already done when someone suffered a head injury, and what we can do is prevent it from happening initially and preventing more serious damage and more serious injury to the brain secondarily as well.
Yeah, what we're doing in the hospital to treat these patients is really optimizing the energy supply to the brain, so making sure patients are intravascularly full, so not hypotensive, making sure their sugars are okay, making sure their oxygen levels are okay. So really you're giving the brain everything that it needs right after an injury to promote as much healing as quickly as possible.
Yeah, and what hypovolemia can do is decrease the oxygen flow and nutrient supply to the brain so you can get the secondary injury. So it's not that the hypovolemia really affects the CSF directly, but just it does cause secondary brain injury.
And one thing that we haven't actually recognized is that resting the brain, because if you don't strain the brain by either doing physical activity or cognitive activities, then you're actually decreasing that metabolic demand.
Thanks for your questions, everyone. Those are excellent questions. Just moving on, moving on in terms of a coach's assessment. So if we have any of the audience members out there who are coaches for hockey teams or football teams or so on, really the coach's assessment, the big thing is to know exactly what happened around the circumstances of the injury and being aware of what happened. First of all, is the player conscious and alert? Is the player oriented to person, place, and time? You know, asking them, do they know where they are and who they are and what day of the week it is? Finding out if there's any other injuries or where else it hurts. Making sure that it's not just a head injury, that there could be, that if there are or are not other injuries associated with it. And I'm going to go over the pocket version of what's called the SCAT-2, or the Sport Concussion Assessment Tool, which is something that, as a coach and even as a paramedic, which Samir will get into as well, you can carry in your pocket, especially in sports where concussions are of a higher prevalence. Now, this SCAT-2, the SCAT-2 is really, it's a tool that's used by sport medicine physicians at Fowler Kennedy Sport Medicine Clinic to track symptom improvement. And it's something, as a coach or a paramedic, you can use as well. The pocket version really just has 3 basic assessment categories: assessing for symptoms, assessing recent memory, and assessing balance testing. And it's really quite sensitive in screening for concussion with all the studies that have been done on it. So this slide here really shows you what the Pocket SCAT-2 is. It's just a little 2-page pocket card that you can actually download for free off that website, that link that's at the bottom there. And again, as I mentioned before, it assesses the symptoms, and presence of any of those symptoms below may suggest a concussion. They are pretty non-specific, at least with the symptoms that are there, and that is just to show that a concussion can really present in many different ways. The second aspect is the memory functioning, and answering all these questions that are here on that list. You can read them for yourselves. Really, those are more sensitive in terms of assessing for concussion than just, you know, asking for person, place, or time, and it's more reliable, at least in terms of determining if it is a concussion or not.
And some studies have been done comparing standard orientation questions like person, place, and time versus these more advanced recent memory questions. And past literature has found that there was no difference in answering basic orientation questions between patients who had suffered a concussion and those who didn't. Now, that's not, no, I don't mean to say that it's not useful to ask those questions, but these recent memory questions you have written in Section 2 of the Pocket SCAT just takes this to another level.
The third part of the SCAT-2 is really just balance testing, so getting them to stand heel to toe with a non-dominant foot and back, and basically just assessing their balance. And if there's any kind of problem with this, then it is suggestive of a concussion. So that's something that can be carried around with sports teams, with the coaches during hockey games and so on.
And those 3 sections really crudely kind of look at the different parts of the brain, different lobes of the brain that Justin alluded to earlier.
Really, the role of the coach, you know, unless you're a medical professional, it's not to necessarily do too much in terms of treatment, but certainly if the player has lost consciousness or has other injuries, such as a neck injury suspected, or, you know, any kind of broken bone or so on, it's really not a good idea to move them just to again prevent secondary injury. If the player, you know, is sort of like the hockey player that we had, it's sort of like the hockey player that we had in one of the cases where, you know, they maybe got their head hit and they're still skating around and then come off the ice. The best thing to do is just remove them from play, get them into a quiet room where they're not going to be stimulated, their brain's not going to be stimulated. Make sure that they're being supervised so that someone's staying with them just in case there is a more serious injury and they do end up losing consciousness or whatever, and then referring them onward for urgent medical assessment. Whether that means calling 911 and getting the paramedics involved, or having an outpatient medical assessment, that's at your discretion there.
And just to further Justin's first point, if you do suspect a more serious head injury where the player has lost consciousness, it is very important to keep that patient still wherever they suffered their head injury, as we are, in more serious cases, worried that they've also injured their neck. Okay, so now I'll take over for the next couple portions of the presentation, speaking directly about specific paramedic tools for assessment and also therapies that can be provided. In general, with these patients, if you get called to a patient who suffered a head injury, it's most important just to adhere to your normal general trauma principles. absolutely don't assume the diagnosis of mild traumatic brain injury if that gets passed on to you. Many intracerebral hemorrhages present with an initial period of lucidity and very mild initial symptoms until further edema develops, and then patients become a lot more ill. But in the initial phases, mild and severe head injuries can often present the same way. So stick to your general trauma principles and be organized. Start off with your primary survey, doing your ABCs and doing a basic GCS score, looking for obvious lateralizing neurological findings, if any obvious spinal cord level injury is present with loss of motor and sensory function beneath it, and checking pupil size. Next, you'd move on to your secondary survey. And because of the wide variety of mechanisms that can cause concussion, other injuries are very common as well. So do a thorough secondary survey and a thorough head-to-toe examination, checking for other signs of injury. With all patients who have suffered a concussion, especially if paramedics have been called to the scene, assume a cervical spine injury in pretty much all these cases. Further points on paramedic assessment: getting a detailed scene history from coaches, spectators, and other players is absolutely imperative. In the emergency room, it's very often we don't have these family members and other spectators coming in with the patient, so we're often left without really a solid history. We just have a patient get dropped off and say, oh, they got hit in the head, but we really don't know, and because these patients are often confused after their head injury, we can't get a good sense of how they were hit, how hard they were hit, if they're wearing any equipment. So anything that you can get there would be very, very helpful. Looking for more sinister underlying causes of head injury, ask for loss of consciousness, seizures directly after the injury, or vomiting. All of these three would put this patient into a higher risk category. If you've decided that the patient probably has an isolated head injury from your primary and secondary survey, complete a thorough examination of the head and neck. And point number 2 here just goes through some specific changes that may be present which suggest a more serious underlying head injury. So unequal pupils, bad visual acuity, and a simple test for visual acuity would just be holding up an IV bag in front of the patient and asking them to read some of the words. If they have hemorrhage of the conjunctiva, contusions or lacerations of the face or head, any obvious head fractures, or penetrating injuries can all suggest more serious head injury than just concussion. Check for C-spine tenderness, neurological deficits, because once again the same trauma that causes concussions can very frequently cause C-spine injuries as well. So for paramedic treatment, immediately stabilize the neck for further assessment. And really for this point, just follow the BLS patient care manual, pages 3 to 30 and 3 to 31 for a head injury, both blunt and penetrating. If you suspect a more serious head injury, so seizures, loss of consciousness, suspected skull fracture, or lots of amnesia, maintain C-spine precautions for the entire transport. Maintain frequent communication as well with all your head injured patients, and what you're doing here is assessing for any change in level of consciousness for the better or worse. Next up, often we will provide antiemetics for these patients in the emerge, and there is nothing special or contraindicated about giving antiemetics to head injured patients. So for the paramedics listening in, just follow your nausea vomiting medical directive in head injuries if people are having a lot of symptoms. Lastly, it may or may not help in terms of alleviating the increased pressure in the head, as we often elevate the head of the stretcher in head injured patients to about 30, 45 degrees, and this can initially be helpful for symptomology. Going back to the SCAT-2 that Justin talked about, now I won't go through it in detail again, obviously, but we absolutely recommend that you print off one of these assessment tools and just keep it in one of those pockets that you guys have. It's very useful for following patients from their initial visit through their rehab. So if possible, try to get at least some of these questions answered at the time of injury. One acute complication from concussion that paramedics or initial responders may see is seizures, and these are acute symptomatic events that happen after a minor head injury, and these are not indicative of epilepsy. They don't occur that often, but about 5% of people with a mild to moderate traumatic brain injury will suffer a seizure directly afterwards. About half of these seizures occur within the first 24 hours and 1/4 within the first hour. So for medics responding to head injuries, don't be alarmed if these patients do have a seizure. Anticonvulsants may be used as part of your seizure medical directive, but it's important to understand that you're really just treating the seizure here, and you're not preventing post-traumatic epilepsy. Other things to say on this slide is that there is an increase in risk to post-traumatic epilepsy to more than 25% in patients who have had a seizure post-head injury. So although it's not immediately indicative of epilepsy, you are at increased risk. So patients who've had a seizure definitely should have urgent medical assessment. Okay, so the next few slides we'll be talking about the long-term morbidity of minor head injuries and speak to the varying symptomology that patients can have lasting up to a few months or even a year or two. Overall, the prognosis for complete recovery is very good in patients who've had a mild traumatic head injury. For all the reasons that we've went through already, it's very important to get assessment and proper treatment early so that physicians can rule out a more serious head injury and obviously follow your cognitive course over a period of time. It's also important to prevent additional injuries by taking players out of the game until they are completely recovered. So post-concussion syndrome in general, that's just a symptom complex that develops after traumatic brain injury, and it's very, very common. Depending on what studies you read, in between 30 and even up to 80% of patients will get some form of a post-concussion syndrome. It's a symptom complex of headaches, dizziness, mood changes, and cognitive impairment. Patients can have any or all of these symptoms. With mood changes, people often report these patients become more irritable, and for cognitive impairment, you can have issues with concentration and with memory, just to give a few examples. Most often, a post-concussion syndrome develops within the first few days and generally resolves by a few months as long as people have received appropriate therapy and, most importantly, taken themselves out of the game or activity that caused a concussion in the first place. About 10% of people who suffer a concussion will have chronic symptoms lasting 1 year. So once again, this point just speaks to the long-term morbidity that we can't ignore with concussions. Post-traumatic headaches are probably the most common element of a post-concussion syndrome, and these occur in up to 3/4 of patients following a head injury. The onset of post-traumatic headaches should be within 7 days of the injury, but some studies suggest that up to 3 months after the injury, people are at an increased risk of developing headaches. Typical migraine and tension-type headaches predominate, and the therapy for post-traumatic headaches is really the same as patients who otherwise suffer quote-unquote normal migraine or tension-type headaches with over-the-counter analgesia. Going back to our point about seizures, so you're a paramedic and you assess a patient with a head injury who's had a seizure. So you've treated the seizure acutely, brought the patient into hospital. Now, in that patient's future, they're going to have at least a 2-fold increase in the risk of developing epilepsy in the first 5 years after injury. Now, mind you, that's a 2-fold increase on your baseline risk. So we're not talking about a huge number of patients, but it does increase your risk. That's important to appreciate. Once again, seizures that happen in the first week after a head injury are not indicative of epilepsy. Those are just symptomatic of the head injury. And once again, prophylactic treatment with anticonvulsants, so either treating a seizure acutely with, let's say, a benzodiazepine, or starting patients on an anti-epileptic medication after head injury hasn't been shown to reduce the incidence of post-traumatic epilepsy. So we obviously don't understand all parts of this phenomenon yet. Post-traumatic vertigo and dizziness, this is also a very substantial contributor to disability. If there's anyone out there who suffers vertigo for any number of other reasons, you can definitely attest to how debilitating vertigo can be. The trauma itself can cause direct injury to the vestibular structures, which is the organ inside of our ears responsible for sensing our balance. The trauma can also cause direct injuries to the vertebral arteries, which supply the back of the brain, the cerebellum, which is responsible for interpreting all our balance signals. And then lastly, the trauma can also cause direct injury to underlying brain tissue with your Q-contracute mechanism, that Justin talked about earlier. In general, post-traumatic vertigo tends to be a little bit more refractory than non-traumatic vertigo, but once again, just like post-traumatic epilepsy, we really don't have any magic pills or treatments to provide these patients. Next, psychological and cognitive symptoms. So these are also very common, and over 50% of patients will report some sort of personality change, whether it be irritability, anxiety, mood changes, whatever, after a mild traumatic brain injury. Patients will often complain of impaired memory and concentration, which going from the sports field to, say, the classroom or your work environment can definitely affect your day-to-day activities. Fatigue and insomnia have also been reported, so sleeping difficulties, either sleeping too much or sleeping too little. Patients can be on either end of the spectrum. It's important for family members really to also understand the significance of these psychological and cognitive symptoms. And you're going back to our little case of Justin, who fell off his skateboard. If he's being a little bit more irritable after his head injury, well, he's not just hitting puberty at the age of 12. He's probably having some mood changes with that pole that struck the middle of his head. So it's important after a head injury to watch out for these subtle changes in mood and cognition, which would hopefully prompt you to get some medical treatment if you haven't already. Lastly, and this has been in the news a lot, we can talk about the cumulative kind of neuropsychiatric impairment that can happen after repeated head injuries. And there is some evidence, very good at this point, that repeated concussions cause permanent injury that we cannot treat really and take away. So these changes are permanent. Permanent changes have been reported in patients' behavior, patients' personality, mood, and also suicidality. Parkinsonism and gait abnormalities have been reported in patients who've had repeated head injuries. And probably what's received the most press out of these is the chronic traumatic encephalopathy that many ex-NFL players has developed. And just recently the NFL put together a commission to study head injury in ex-NFL players, and the results are actually really surprising. They did a phone survey of over 1,000 former players and found that 6.1% of players over the age of 50 reported that they had received a dementia-related diagnosis, and that's 5 times higher than the cited national average, which is just over 1%, according to this report. As well, players who were under the age of 50, from ages 30 to 49, reported dementia-related diagnoses at a rate of 1.9%, so about 2% of those people, which is 19 times the national average of that age, which is 0.1%. So, again, not all of our family members or friends will be participating in professional level sport, but that being said, this speaks to the importance of recognizing and treating concussions very early and preventing secondary injury from happening. Next, I'll pass the presentation back to Terry Lynn to talk about some of the evidence about return to play or activity guidelines.
So what can we do to help our players stay safe and support them? I mean, the first thing we do is we encourage them to seek that medical treatment in the first place. That they get the appropriate assessments, that they are transferred to the hospital, and then that the diagnosis of concussion is made. The return to play or these activity guidelines were also established in Zurich. And they basically are a stepwise sequential pattern of different levels of activity that the player moves through as he progresses and as symptoms improve. So in step 1, what's required is complete physical and cognitive rest. So we're talking no school, not going to work, no activity, no computer, video games, cell phone, absolutely nothing. Rest and absolute rest. And you do this until all the symptoms are gone. And then once the symptoms are gone, you wait a full 24 hours before you would proceed to step 2. Again, the individual still could be confused. They still could have other issues. You want to make sure that you're asking them the appropriate questions so that you understand that they are getting better. So in step 2, light aerobic exercise is where we want to start. So that includes going for walks or stationary cycling on the computer. But these are just for short periods of time, like 10 or 15 minutes. And you should really remain with that person and observe for signs and symptoms. If they initially had vertigo, nausea, you'd be watching for those symptoms, but you'd also be probing for other symptoms. Just because someone presents initially with a bang to the head and they have a headache does not mean that days later they could not develop other symptoms as well. So probing for these are important. Again, we want to wait until all signs and symptoms are gone, that the person can tolerate light aerobic exercise. And this is simply our goal here is to increase the individual's heart rate. Don't do any resistance training or anything at this point. During step 3, we can start doing sport-specific activities. And as coaches, you may have children that are coming back to play hockey or play soccer. They can do skating, they can do running, but they cannot really participate in any gaming. Nothing that's going to put them at risk of any kind of body contact or abrupt jarring motions. At this point, if somebody's up to step 3, depending on how long it took to get here, it's really important to get some socializing in, even if that's for short periods. So we want to continue always asking, probing, looking for the signs and symptoms. If you're a parent out there and you've got someone who really wants to push for sports, they can be quite elusive. They may say that they don't have a headache anymore. Mom, leave me alone. I'm fine, I'm fine, I'm fine. It's important that we watch them, we observed our loved ones. We see if they're squinting when they're watching TV or if they're retiring early or for changes in behavior at all, because that would indicate that really they're not as well as they think they are. At this stage, we can start adding things like homework for children, or in adults, maybe doing some banking, paying some bills. I mean, we talked about activity and increasing activity little by little, but we also want to increase the cognitive load on the brain as well, little by little, so that we're not putting too much cognitive strain on the brain, because that increases the metabolic rate, like we mentioned before. So we're now free of symptoms. We've been going to hockey, or we've been skating. We've been running. We've been symptom-free for 24 hours. We can move forward. If we do develop symptoms again, we're going to have to regress back to step 2. Take it back a notch and start resting again, just going for those walks for short periods. We don't want to keep moving ahead, and we don't want to keep pushing the body too hard. So in step 4 here, this is more vigorous activity, and this includes drills, but non-contact. So if you've got a young player, I know some parents have requested that their son wear something bright and reflective, just so that he can be identified as someone who has that the other players are supposed to not hit, not push. And that's going to help keep him safe while he's out there doing his drills and practice. Starting half a day at work or school. Saying that with work, when we're talking about adults, some people have very physically demanding jobs. And we can start in this phase to do some resistive training or weights, but if you're dealing with a roofer that's up and down a ladder, a half day at work is a little unreasonable. And you want to really push that people stay with this, because if they don't, if they actually suffer another concussion before that brain has had a complete time to recover from that injury, the cumulative effects are going to be that much worse, and it's going to take that much longer for the individual to recover. As well, you want everyone that you see to actually get that diagnosis of a concussion. If it's a child in school that's had ongoing difficulties, they're not going to be able to get the support in the school system that they need to help them exceed until they're over this post-concussion syndrome. And if it's an adult who has to lose considerable amount of time off of work because of chronic vertigo, they're not going to be able to get any financial support either. So you see something happen, you should always urge for treatment. So we've been on step 4, 24 hours, everything's going well. Before we can move on to step 5, that individual should be getting a clearance by their doctor. So if you are a coach, you're going to want to see a letter from the doctor saying that, yes, my son has been cleared for sports and with body contact. Again, you keep extending the period of time. We're basically up to all of our regular activities, regular work day, and we'll stay in this here for as long as it takes till we're well. And then step 6, of course, is return to full play. So the guidelines, they are guidelines only. They're not cast in stone. Some players, they can move through them within 7 days. Their symptoms are transient. They only occur initially, and they're gone. And they go through it 6 days, they're back at play. Other people, it can be considerably longer. We're looking at months before they're actually back. And in Sidney Crosby's case, he's still not back playing hockey yet. They don't replace the advice of a physician, so you always want that diagnosis. And each individual is going to pass through this at their own pace. Now, when we're talking professional versus amateur sports, professional teams have their own physicians that do their assessment. There's a coach and physician there. When we're dealing with parents in amateur sport, it's a little more difficult. Just remind the parents why we go to such effort, why you want that doctor's note, why you think it would be better to identify that player as special when they're out playing. It's basically to protect them. So in children and adolescents, the brain are still developing, and symptoms actually may take longer for them to resolve. And early aggressive referral is important. And like I suggested, if they do require support in school, without a diagnosis, they're not going to get it. And of course, when we're dealing with kids, they can't appreciate any long-term consequences. So we really need the adults in their life to advocate on their behalf. There's a link here to a video, and it's a hockey video that talks about primary prevention in hockey. And I would encourage anyone who's got a hockey player in their home to watch it.
Okay, so now we'll be wrapping up this presentation. Just to go back a few slides, we've had a couple questions come in. Our apologies that we've had a bit of a delay, but question number 1 was related to alcohol and about the patient who's drunk at a bar, gets in a fight or falls and hits his head. Can alcohol drastically affect concussion symptoms? So to answer that question, in chronic alcoholics, yes, absolutely. Chronic alcoholics, they don't have the same, if you can say it, their nutritional status isn't as good as a normal patient. They may have chronically low blood pressure, other comorbid disease. So those patients, without a doubt, would be at increased risk of worse symptoms and probably a delayed recovery as well. And then that goes for most illnesses in alcoholics. Secondly, people who've had a concussion can be more susceptible to the effects of alcohol. So for possibly the first few weeks or months after a concussion, you can drop down your bar bill a little bit. You probably get drunk a little bit quicker. If we don't recommend that at all, but if you are going out, you probably save some money. In the acute situation, does it affect your symptoms? No, acutely being drunk will not put you at, an increased risk of suffering concussion, but what it does do is makes it harder for physicians to assess. If we see a patient after a head injury who's also drunk, if they are, if they have issues with orientation, if their balance testing is off on the SCAT tool, if they are complaining of some lightheadedness, it's really tough for us, the physicians, to say whether those symptoms are due to the concussion or the alcohol. So in those cases, those patients will often just be monitored in hospital until their alcohol levels are back to negative or a normal level, and then they'll be reassessed again.
Yeah, I would even just add that even after the acute alcohol intoxication, a lot of these symptoms on the concussion tool are consistent with someone with a really bad hangover, to be totally honest. Sensitivity to light, blurred vision, nausea, that kind of thing, headache, those are all things that are on the SCAT-2 in terms of symptoms. And alcohol just really messes up your assessment for a concussion, and not just for a concussion, but really for any kind of traumatic injury. It makes it really difficult to determine if someone has a serious injury or even a concussion when alcohol's in the picture. So really we're looking, the point of this talk is really looking at sports and other things like that don't really involve alcohol as much.
Okay. Thanks, Justin. And then thank you once again for all the questions, and please keep bringing them in if there are any. Sorry, we're just trying to figure out which where we're missing a slide here. I'll keep going with. Oh, okay. So take-home points, you guys can definitely just read those, and feel free to pause and go back on the webinar. So the only way to heal a brain is to absolutely rest it. That's the most important thing. So follow the graduated return to play activities, even though they can be a little bit cumbersome. On this next slide here, we have some useful links that everyone can go to. We have a hockey video for coaches and for parents at the very top. In between, we have a CBC link which speaks to the common misperceptions of concussions. And our last link there is to the pocket assessment tool that we use. Here are the references for our slide, and again, please feel free to read up on any of these, or they were all very, very useful. Just to go back to the cases at the beginning of the presentation as well. Now, the majority of you did agree that those 3 patients did suffer a concussion, and that is absolutely right. Our goal with presenting you those 3 cases was really to give you cases on each side of the spectrum from concussion, patients who are just a little bit dizzy after head injury, to ones who have had more serious trauma potentially and have suffered a seizure. So any of those and anything in between is a concussion. So good job on those questions. Lastly, to finish up the presentation, I'll pass it back to Dave, and please feel free to ask or type away any more questions that you have. Thank you very much for listening in on the webinar. We hope it's been a good presentation, and hopefully we've given you some points that you can go home with and use in the future to assess your patients or family.
Great. Thanks, Amir. We do have one question here. I was hoping somebody had asked live, but unfortunately there's no mic there. Does sedating a combative head injury patient have any adverse effects or complications from sedation? And that's a great question, because you just made Samir go, ooh.
That is a great question, and this probably if this question was from a paramedic, I'm assuming you're going back to the combative patient medical directive. And this is one of the more difficult cases. This is why I believe this is a mandatory patch point for medics. Patients who are extremely combative after head injury, it can be that they are just combative people at baseline, obviously, and maybe need some sedation, or their agitation can be due to a more serious head injury. So Our recommendation there would be to avoid using sedation in the head injured patients where possible, especially if you know, all the medications we use will decrease patients' level of consciousness, and in someone who's had a head injury and in the field, you're unable to say you know, with any great certainty whether or not something more serious like a bleed is present. So you know, in these cases, I would definitely use discretion with using sedation. But that being said, if paramedics or other witnesses are being put in danger and you're unable to assess a patient because of a head injury, we absolutely would be would recommend using some sort of sedation.
The other part of the, excuse me, the other part of that as well is that if the patient is, you know, so agitated and combative that they're going to be causing a lot of injury to themselves and not just, you know, the paramedics and witnesses, then it's certainly something to consider. You know, they're always going to be putting themselves at risk, I guess, of hurting themselves, but it just makes it difficult for, you know, later on once you've arrived at the hospital for the physician to assess their level of consciousness.
Okay, great. Well, thank you, everyone. We've reached our 1 hour mark, so I'm glad that we're on time today. It's nicely done. So I really want to thank Samir and Justin and Terry Lynn from the trauma program for being involved today. I want to thank all the participants, and once again, Chris in Australia, you win the prize for the longest participant once again. Yeah. For those who are interested, we always do record this presentation, and hopefully by later today, if you go to the base hospital website, you should be able to have access to that recorded webinar, so you could watch this in its entirety. Or if you prefer it in the other way, we also do load this up just in a PowerPoint format so that you can go through the individual slides by yourself. And especially if you're looking for the references or the links, you'll be able to see it off that PowerPoint presentation much better. So again, I want to thank everyone for participating today, for our presenters, and hopefully it was a useful presentation for everyone. It was some great comments, and I thank everyone for the chat and keeping me going. Chris says he's looking forward to being back in our time zone when he comes home in a couple of months. So we'll look forward to seeing you when you come back, Chris. And we look forward to seeing everybody again on our next webinar, which will be in October. Drs. Llewell and Matt Davis have a webinar provided for us on 12-lead ECG based on Matt's research that he's done here with pre-hospital 12-lead ECGs. So we look forward to seeing everybody in October. Once again, thanks, and we'll see you soon.